It's that time of year again. Time to look back at the old year and look forward to the new one. I'm Dr. Neil Skolnik, and today we're going to review the most important guidelines of 2023. If you learn nothing else this year, learn these guidelines. I guarantee that one of these guidelines will come up at least every day in the office. The most important and surprising guideline of the bunch was that the American Academy of Family Physicians put out a guideline on target blood pressure for the treatment of hypertension, and the target for AAFP is a blood pressure less than 140/90. This was surprising because the American Heart Association, since 2017, recommended a blood pressure target of less than 130/80. Remember, the American Diabetes Association recommends a blood pressure target of less than 130/80 for people with diabetes. The AAFP's rationale for this recommendation was based on a comprehensive review of the literature showing that there was no difference in mortality or stroke with lower blood pressure targets, though there was a small additional benefit for decreasing the incidence of MI. But remember, if you have a lower blood pressure target, there's increased risk because you generally need more medicines. I wrote about this issue of competing guidelines in JAMA Internal Medicine a while ago, and what I said was that a lack of consensus complicates the decision-making process for practicing clinicians, and it asks us to be experts in deciding which expert guideline best interprets the evidence. That's not reasonable. This is a plea from the trenches. We need more clarity to guide us with less robust confusion. My take, to give some clarity to this, is that a blood pressure target less than 140/90 is fine for most people, and less than 135 or 130/85 or 80 may be preferable to those with existent ASCVD. Let's now go on to talk about COPD. Here, the big news in the GOLD guidelines was an increased emphasis on the importance of decreasing exacerbations as a target of treatment. Exacerbations are bad, both because they make people feel bad and because they lead to a loss of lung function and increased mortality. There actually were two large trials, each 1 year long, that enrolled individuals with moderate to severe COPD who had 2 or more outpatient exacerbations or 1 or more hospital-level exacerbation, which in post-hoc analysis suggested decreased mortality in individuals who received triple therapy compared to those who received dual bronchodilator therapy. These trials led to some of the emphasis that we talked about in the guidelines. The guidelines made a real effort to make the treatment algorithm more straightforward, but it's still a bit cumbersome and difficult to remember. Since we're being concise today, I'll give you my quick take. Please look at the longer discussion that we did earlier. Basically, we're good to start people who do not have a strong history of exacerbations with either single or dual bronchodilator therapy. If someone has further exacerbations and they have more than 100 to 300 eosinophils on a CBC with DIF, then consider increasing to triple therapy with a LAMA/LABA ICS. If they're coming in for the first time with a strong history of exacerbations, consider going directly to triple therapy with a LAMA/LABA ICS. Next up, depression. We see a lot of depression in the office, and it is of critical importance, and often it takes a while to get someone into a psychiatrist if that's what we recommend. So it's important that we know the most current guidelines from the American College of Physicians clinical guideline on the treatment of depression. First, you want to make sure that the person actually has depression, not bipolar disease, because they're treated differently. Then, for mild depression, CBT is preferred over medication. This is a surprise for many of us. CBT is recommended because there's good evidence that CBT works as well as medication without the side effects. If CBT isn't available, then a second-generation antidepressant, such as an SSRI, SNRI, bupropion, mirtazapine, or some of the newer agents can be used. Also, aerobic exercise can improve depression. For moderate to severe depression, the initial treatment of patients can be either CBT, a second-generation antidepressant, or a combination of both. Then, and this is critically important, because 70% of people don't achieve a full remission with initial treatment, it's important for us to know the next steps. We can augment the initial therapy with CBT if that wasn't used initially. We can switch to a different second-generation antidepressant, or we can augment what the patient is currently on with the second medication. Usually that second medicine is going to be mirtazapine, bupropion, or buspirone. Let's now go on to talk about osteoporosis and the American College of Physicians guidelines. The use of a bisphosphonate as first-line treatment to reduce the risk of future fractures is a strong recommendation in postmenopausal women with osteoporosis and is a conditional recommendation for older men with osteoporosis based on there not being as much evidence. For women over 65 with osteopenia, the guidelines suggest an individualized approach, assessing the level of risk for fracture, which includes increased age, low body weight, current smoking, hip fracture in a parent, fall risk, and a personal history of fracture. Then the decision about treatment is based on the level of risk. Since increasing duration of use increases the risk of atypical femoral fractures and osteonecrosis of the jaw, bisphosphonate should only be used for 3 to 5 years unless someone is at extremely high risk. Let's now briefly discuss the 2023 American College of Cardiology's expert consensus decision pathway on the management of heart failure with preserved ejection fraction. Now, this may not seem real important to everyone now, but since HFpEF, that is, heart failure with preserved ejection fraction, is associated with diabetes, obesity, and hypertension, this is something we're seeing a lot more of, and we are going to continue to see a lot more of. To diagnose HFpEF, check for an elevated NT-proBNP greater than 125 and evidence of diastolic dysfunction on echocardiogram. Be aware that patients with obesity and HFpEF may have up to 50% lower BNP concentrations than those without obesity. The main treatment for HFpEF, and this is a big change over the last couple of years, is now an SGLT2 inhibitor. Loop diuretics can be used as needed to control volume status. In men with an ejection fraction less than 55 to 60%, and for women with any ejection fraction, a 2B recommendation, so not as strong, is that we can consider the use of a mineralocorticoid or an ARNI or an ARB if an ARNI isn't used. Let's go on now to the North American Menopause Society's position statement on non-hormonal treatment of vasomotor symptoms of menopause. 80% of menopausal and postmenopausal women have hot flashes and night sweats, called vasomotor symptoms, or VMS, and they last a lot longer than many of us appreciate, with an average of 7 to 9 years of length. Postmenopausal estrogen therapy is the most effective treatment for VMS and is considered first-line therapy. That said, many women and their physicians would like to avoid the use of estrogen because of the increased risk of DVT and PE, as well as an increased risk of breast cancer. So, here are choices. Among lifestyle-based interventions, weight loss reduces the frequency and severity of VMS. Supplements don't work. FDA-approved medications that decrease the frequency and severity of VMS include the newly approved fezolinetant, approved by the FDA in May of 2023. Fezolinetant is the first in a new class of medications, the neurokinin B antagonists, which work directly on the thermoregulatory area of the brain to decrease the frequency and severity of VMS. Also FDA approved about 10 years ago is paroxetine at a low dose, 7.5 milligrams daily, which is considered modestly effective. Non-FDA approved medications that are recommended based on the evidence include SSRIs, SNRIs, gabapentin, though usually at a pretty high dose, 300 milligrams 3 times a day or higher, and oxybutynin. Let's now talk about breast density reporting on mammograms, which is a new FDA regulation that this year is now required on all mammogram reports nationwide. And these reports go not just to us, remember, but also to patients. So is this important? Well, it is. And we're going to be asked a lot of questions about this. Breast density is reported as either class 1 or 2, which is not dense, or categories 3 and 4, which are heterogeneously dense and extremely dense, respectively. Increased breast density correlates both with increased risk of developing breast cancer and a decrease in the sensitivity of mammography to detect that breast cancer. So the big question then is what to do about it. Bottom line here is we can consider ordering additional testing, most commonly an ultrasound, which also can lead, though, to false positives and more biopsies after discussion of the risk and benefit with our patients. It's important to recognize that the official ACOG stance is that this does not need to be routinely recommended. Now let's touch on fatty liver and the American Association for the Study of Liver Diseases guidance document. Non-alcoholic fatty liver disease, NAFLD, refers to all grades of fatty liver. Non-alcoholic steatohepatitis, or NASH, refers to when the fat in the liver leads to an inflammatory reaction, which in turn can lead to fibrosis. It's estimated that 25% of the United States population has NAFLD, and 20% of those with NAFLD have NASH. The first step in the evaluation of NAFLD is to look for other etiologies of liver disease, ask about alcohol use, check an ultrasound if it wasn't already done, check hepatitis serologies, and consider a ferritin and a celiac panel as well. Other testing can be done as clinically indicated. Next step is to use a risk calculator like the FIB-4 score, which uses a simple algorithm where you input the patient's age, their level of ALT and AST, and the platelet count. Patients with a FIB-4 score less than 1.3 are unlikely to have advanced fibrosis. They can receive lifestyle advice about diet and exercise and periodic assessment. If the FIB-4 score is intermediate or high, that is greater than 1.3, then vibration-controlled elastography testing, often known as FibroScan, can be ordered. Elastography measures liver stiffness, which worsens with increasing severity of liver fibrosis. If elastography is less than 8, then the likelihood of advanced fibrosis is low. If the patient then can be periodically reassessed. If the elastography score is greater than 8, or if the liver function tests are persistently elevated, then the guidelines recommend referral to a gastroenterologist for further evaluation. There are 3 potential approaches to treatment: lifestyle, medication, and bariatric surgery. Please look at our previous column to go over those details. For updated Bayer's criteria for medication prescribing in older adults, I'm only going to mention 2 things. 1, don't use aspirin for primary prevention in older adults. They have higher risk of bleeding than those who are younger. 2, for treatment of AFib, DVT, and pulmonary embolus, apixaban is preferred over warfarin, rivaroxaban, and dabigatran. They all have more bleeding than apixaban. Finally, the American Heart Association's statement on vaping. This is important because right now 15% of high school students vape, and the scientific statement says, and are you ready? Vaping is bad. Look at our original column for more details. I'm interested in your thoughts. What do you feel are the most important guideline changes in the last year? Are there any that we've left out? Let me know and we can learn from each other. Please leave your thoughts in the comments section below. I'm Dr. Neil Skolnik, and this is Medscape.